Welcome and thank you for joining today's webinar. This is the second of 3 sessions in this webinar series on child protection and health integration during major disease outbreaks, hosted by the READY Initiative, which is funded by the Bureau of Humanitarian Assistance. We are happy to provide live interpretation to French and Arabic for today's webinar. If you're interested in listening to the session in one of these languages, please click the globe icon that says Interpretation at the bottom of your Zoom screen and select your desired language. During this webinar, we encourage you to ask questions using the Q&A function. Access to today's recording will be available on the READY website. It is now my pleasure to hand it over to Sarah Kalisker, the lead technical advisor for the READY Initiative. Sarah.
Thanks, Vasika, and welcome everyone, and thanks again for taking the time out of your busy schedules to participate in READY's second webinar in this 3-part series focusing on integrating child protection into the design and operation of isolation and treatment centres. Very quickly about READY. So the READY Initiative has been in existence since 2018 and funded by the Bureau for Humanitarian Assistance, BHA. We're a consortium of partners with Save the Children as the lead, Johns Hopkins University Centre for Humanitarian Health, Centre for Communication Programmes also at Johns Hopkins, UK Med and the Humanitarian Leadership Academy. Our goal is for NGOs to have the tools, knowledge and skills to support crisis-affected communities and local authorities to effectively respond to major epidemics and pandemics in humanitarian settings. And we do this on a global level, producing things like guidance, tools, and trainings. You can access more information on our website, which the link should now be in the chat. So I'm extremely pleased that we're here today, highlighting this very important subject of integrating child protection into the design and operation of isolation treatment centres. And I wanted us just to take a minute to look at this picture. This was taken in the Ebola outbreak in Sierra Leone in 2015 and shows the admission process from ambulance into the Ebola treatment centre. And I want us to imagine for a second that this is you as a child without your parents, caregivers or loved ones, extremely unwell from a life-threatening illness and with strangers of whom you cannot see their face or perhaps you can't even speak their language. Often for us as health actors, the nature of the emergency and the sheer devastation of the disease spread means we quickly become overwhelmed, focused and consumed by the daily running of these big centres with strict prevention and control procedures. This I have found is not only true for Ebola, but also other major infectious diseases such as cholera, measles, and more recently, the response for COVID-19. Because of this, child protection integration, though very unintentionally, can often become an afterthought instead of one that underpins our interventions and informs our response from the very beginning. I hope that in this webinar, we will start to understand why child protection considerations are needed in the design and layout and operation of an isolation and treatment centre, and explore how child protection needs can be integrated with some examples from our fabulous case studies. I hope that you'll walk away with some firm ideas and inspiration as well on how to do this within your settings and your own responses. So to help us today, I'm joined by some excellent presenters and panelists. First, Nidhi Kapoor, Child Protection Specialist and Independent Consultant. Nidhi is a protection, gender and inclusion specialist and is currently supporting many activities with us in the READY Initiative to improve collaboration between the health and child protection sector. Jean Sayanda is a humanitarian child protection advisor within the Global Centre for Humanitarian Technical Team at Save the Children. Jean is currently the child protection lead for the READY Initiative. Dr. Aisha Kadir, Senior Humanitarian Health Advisor for Save the Children, is a paediatrician and public health researcher whose work is focused on understanding and meeting the needs of children and families in deprivation and crisis settings. Nurien Zunong, Senior Humanitarian Health Advisor with Save the Children. Nurien is a humanitarian health professional specialising in health programme planning and implementation in humanitarian settings. Dr. Charles Holder, a medical doctor and global health specialist working with the International Organization for Migration, better known as IOM. He's been supporting the humanitarian health response in Cox's Bazar for the Rohingya refugees for more than 7 years. Dr. Hans-Jörg Lann is a paediatrician and a lecturer of global child health at the University of Witten in Germany, and advisor for pediatrics and critical care for the Alliance for International Medical Action, better known as ALIMA. So what will be in our webinar today? So first, we'll aim to define key terms and establish exactly what an isolation treatment centre is and why it is often necessary. We will then look at why we need to consider child protection needs and risks when thinking about isolation treatment centres and what happens when we don't. Then we'll explore how we integrate child protection into design and operation of isolation and treatment centres, followed by some insightful examples from several recent major disease outbreaks in the Rohingya refugee camps and Ebola in Uganda. And as always, we will finish with a chance to ask questions to all of our panelists and presenters. But please don't hesitate to start putting questions in the Q&A function, and our team can begin answering them there now. So first, what is infection prevention control, otherwise known as IPC? This is a practical, evidence-based approach preventing patients and health workers from being harmed by avoidable infections. It's very common now in the aftermath of COVID-19, especially and other major disease outbreaks, to think that infection prevention control is only the practice of wearing masks, gloves, and goggles, but it's much more than that. Infection prevention control influences all aspects of healthcare, including hand hygiene, injection safety, antimicrobial resistance, and how health facilities operate during and outside of outbreaks. And it aims to ensure that patients and health workers do not come to unnecessary harm from contracting avoidable infections, and puts measures in place to mitigate against this. Quarantine is the restriction of activities for the separation of persons who are not ill, but who may be exposed to an infectious agent or disease, with the objective to monitor symptoms and ensure early detection of cases, therefore reducing further spread of the disease. So this might be when a perfectly healthy person is quarantined in a centre because they are a contact. Isolation is the separation of ill or infected persons from others to prevent the spread of infection or contamination. So this is when they are confirmed to have the disease, but and are also considered to be infective. So then what is an isolation and treatment centre, what we're talking about today? So this is usually a dedicated space for the isolation, which is the separation of ill or infected persons and treatment of those with the disease. Sorry, Fasika, next slide, please. It is usually dedicated to isolating and treating one disease, although it should be able to care for many other conditions or infections. So it can often be a building, a new one, a repurposed site, or a temporary structure. And their design, layout, and operation are heavily influenced by the context. For example, is it a low or middle income country or humanitarian setting? The disease severity, so how fast it is spreading, and how the disease is spread. So is it through bodily fluids? Is it airborne or droplet, or through fecal, oral, or contaminated water? Some isolation treatment centres may just be put up once and stay once, or some may be permanent and open every season for yearly outbreaks that are common, for example, cholera or diarrheal treatment centres. They are almost always run by health actors, but are multi-sectoral in nature and relying on the support of other sectors such as WASH, logistics, shelter, nutrition, mental health, psychosocial support, and of course, child protection. Examples, as I'm sure many of you are familiar with, are Ebola treatment centres and units, cholera treatment centres and units, or more recently, we've seen many severe acute respiratory infection isolation and treatment centres that you can see in some of the pictures displayed here. So now I'll hand over to my colleague Jean to talk us through some of the protection risks and isolation and treatment centres that can often pose, through the protection risks that isolation and treatment centres can often pose to children. So Jean, over to you.
Thank you so much, Sarah. Good morning, everyone. Good afternoon, everyone. Thank you for joining us today. So just focus on the child protection risks that may emerge or might most likely will emerge during isolation and treatment. So while isolation and treatment centers aim to provide life-saving interventions to children, their caregivers and other community members, they do have a potential to introduce some risks. This can create unintended and often unnecessary harm to children. Potential risks factors will vary by context, but the common ones that we can identify are family separation, which may result from the isolation and treatment center in the event of death or illness of the primary caregiver. Health practitioners may encounter orphans, unaccompanied minors, separated children who may lack traceable caregivers. Another likely protection concern is intentional and unintentional neglect of children in the center and in the community, which may be a likely occurrence. Children in isolation and treatment may also experience a disruption of access to crucial services, which are linked to their survival and development. And such services might be services that support their social services and education services, meaning that any holistic response should be conscious of this and should connect children to the necessary basic services that are needed, which include education and social services. Mental health and physical needs are also likely to increase. These are linked to the traumatic experiences that come up as a result of the illness, such as grief and bereavement. There is heightened loss of parents, caregivers, brothers and sisters, other family members, relatives and friends, community members. In some settings, survivors may also face social stigma upon discharge and return to their communities, as well as survivors' guilt. Children also need their unique physical needs met during while in the isolation treatment center. For example, their nutrition needs are different from those of adults, so those are things to consider. Children may also be predisposed to dangers within the isolation facilities and harm, including physical and sexual abuse by workers and other patients. It's important for these considerations to be put in place, such as sleeping arrangements and lockable toilets, and responsible adult supervision during the isolation period. To avoid children being exposed to further harm. So there are many risks which can be predetermined and prevented and addressed through proper integration of child protection considerations in the design and operation of the ICT isolation treatment at the onset. We are going to do a poll before we go into how to integrate CP into the isolation and treatment centers. And so over to, and the poll will be focusing on, yes, thank you so much, Fasika, for putting on the poll. So the poll will be focusing on the biggest challenges of integrating child protection into the design and operation of isolation and treatment centers. And the poll, so basically choose as many answers as you can, and the results, which we know will be very interesting, will be handled during the question and answer section. So over to my colleague Aisha to continue with the next session. Thank you so much.
Thank you, Jean. And I think, first and foremost, I'm just going to start with I think was probably the obvious, but health professionals don't need to be child protection specialists in order to design safe and effective care for children during an outbreak response. What we need to do as health professionals, is to work closely together with our child protection colleagues when we're designing and also during operations to make sure that we have the best possible arrangement to treat patients effectively and to promote healing. So by working together, we can pool our respective expertise and make sure that children's needs are met, and also that they will not come to harm because of the design and treatment center. So there are a few groups of children we need to consider. There'll be children who become infected and require admission and treatment. And these children may have siblings at home who are left at home, but who are both exposed now to the infection and potentially also left without a caregiver. So they're at risk for a host of health and safety concerns. Caregivers maybe accompanying a child patient as a healthy sort of caregiver accompanying the child, or they may be admitted because they themselves are infected and ill. And then children with disabilities may require specific support. Unaccompanied children who are admitted for healthcare are particularly vulnerable to exploitation and abuse. And they're also at risk for inadequate treatment because they don't have a caregiver there to support them. This becomes even more difficult when there's a high patient load and staff may not be able to provide adequate attention to the unaccompanied children to ensure that they both get treatment as well as food and fluids and are kept clean and are also comforted. So a sense of safety and comfort and a space to play are actually quite critical parts of the healing process for children. In the design of an isolation and treatment facility, we have to balance the treatment needs and the infection prevention and control measures that are needed with other health needs and safety needs of all patients. So it goes without saying, a child should never come to harm while receiving care. They should not be put at risk for physical or sexual abuse or exploitation. And the design of the center should also consider other kinds of child safety risks. So the sickest children are ones who don't play, who may not even cry, but when their health is improving, they begin to show curiosity in the environment around them, and they can be at risk of injury or ingestion, especially in a healthcare setting. So measures need to be in place to make sure that children don't have access to disinfectants, medications, sharp objects, things that they can either sort of eat or drink or injure themselves with while they're playing and exploring. Also, the way care is provided can be done in a positive and health promoting way, or it can be harmful. So, for example, separation from caregivers is known to be harmful. It should only happen if there's no other option. There are very few situations where separation is indicated. And also, children of different ages have different treatment needs. So a newborn, a 4-month-old, a 5-year-old, and a 13-year-old all have quite different care needs. Children, and especially young children, can actually be traumatized by care if they're forced, or if they witness others being forced, or they're seeing people die. So the design of the isolation and treatment center can be adapted to minimize these kinds of traumatic experiences while still maintaining high quality care, making sure the children survive. And training health personnel on how to speak with children and how to provide care for children. And this is also a critical piece, is the clinical care of children in an effective and a non-threatening and age-appropriate way can all make a huge difference to the treatment process and to the outcomes. So these kinds of considerations are essential to provide effective care. And in the spirit of intersectoral collaboration, I will pass over to my colleague Nidhi to talk about some design considerations in detail. Over to you, Nidhi.
Thank you, Aisha. Indeed, the needs of children can be integrated into the design of isolation and treatment centers in a number of practical ways. And of course, the exact scope of what can be offered may differ according to local circumstances, as well as any prevailing infection prevention and control measures. These will obviously need to be respected. Even so, measures can be taken to render isolation and treatment units more child-friendly. So what are these? Their design needs to consider safe sleeping arrangements for children, whether this be in family rooms or wards, in the event that they're accompanied by a caregiver, or overnight monitoring of same and different sex pediatric or mixed wards. Toilet facilities should be lockable and well lit, not to mention accessible. Centers can have a designated space or child-friendly corner inside and or outside. These can be brightly decorated with paint and textured walls. They could contain art and recreational materials. Ventilation and natural light are also important considerations. And special attention should be taken to choose items that can be easily sanitized. Another idea would be to have happy hours that can be scheduled throughout the day for children to access nutritious snacks, as children often need to eat more frequently than adults. During these times, children may enjoy some songs, stories, or other fun activities, again, with strict adherence to infection prevention and control measures. This may be in small groups, in recovery wards, or physically distanced, or held outside, for example. And stocks of appropriate, age-appropriate furniture, supplies, and other materials can be procured and pre-positioned as part of outbreak management. So think of child-sized furniture, accessible hand washing stations, hygiene supplies like diapers, child-sized masks, age-appropriate clothing and underwear, child-friendly uniforms for workers, toys and other learning and recreational materials that can be easily sanitized. Consider also the needs of different categories of children, like Aisha mentioned, especially, for example, unaccompanied children, children of diverse ages from infants to adolescents, and children of diverse abilities and disabilities. Appropriate accommodations should be made or anticipated for children with different types of disabilities. So this should be considered from the outset when designing an isolation and treatment center. Let me pass back to Aisha now to talk about some operational considerations.
Thank you, Nidhi. So I mentioned separation before, and I want to mention this again. There are very few instances where separation is necessary, but there are some. So Ebola is one of the exceptions where separation may be needed of mothers and newborns or from children and their caregivers. But this is actually much less frequent than, as we saw with COVID, separation is much more frequently done than is necessary. And we still don't appreciate just how harmful separation is for both children and their caregivers. I could speak for hours about this. And it actually, Médecins Sans Frontières recently had a Pediatric Days conference where half a day was spent discussing the physical, psychological, and long-term health harms to mothers and infants when they're separated, so from the newborns. So in short, learning point here is we should only separate when no other option is available. However, if it is necessary, then of course we should separate. There are a number of things that can be done to improve the care of children in isolation and treatment centers that both reduce the safety risks and also improve healing. So providing patient-centered care is not just helpful, but actually improves compliance with treatment and can improve treatment outcomes. So speaking directly with children and including children and their caregivers in decision-making is one key thing. And by this, I don't mean to ask a child if they want the treatment. Like, don't ask a child if they want the IV cannula or a tube put in their nose. The treatment itself is not likely to be optional. However, it helps to ask which hand, or ask them things that they can have some control over, so they participate in their care. So they have some sense of control and participation that gives them a degree of assurance and helps them to comply. So this is really important for how the child patient experiences their care, and that experience impacts their outcome. And it also impacts the whole care process, because once a child feels like they're being attacked, then they will naturally resist. But if they feel like they understand, or if they feel like they're part of it, then they can more easily comply, and it's easier for everyone. So it's really important to try and make that the best possible experience in a very difficult situation. Children can understand quite a lot when we speak to them in a way that they understand. So it's important to communicate with children about the illness and about the treatment and about the infection prevention and control measures in an age-appropriate way. Including the caregivers in the whole care process improves quality of care and leads to better outcomes with fewer complications and earlier recognition when complications do occur. So similarly, it's critical to recognize when a child or a caregiver is experiencing psychological distress and support them. And this may be as simple as having a staff member look after a child to give some respite or rest for a caregiver who is admitted with the child. Staff should be trained in psychological first aid for both children and adults, and support pathways should be identified and established when referral is needed. I'll hand over again to Nidhi to tell us a little bit more about some specific child protection operational measures for health facilities.
Thank you, Aisha. Protocols and guidance for staff should include guidance on how to make care safe for children throughout the entire care pathway. So from triage and admission, throughout the period of inpatient care, and also upon discharge. These protocols should also aim to prevent family separation and to promote family unity. As with the facility design, protocols should be developed with support from child protection colleagues. Some key considerations to think about is fully documenting child, caregiver, and/or alternative care contacts at admission. to facilitate regular, if not daily, communication between children and their caregivers. If in-person visits are not allowed, or if the child is unaccompanied, think about using video and voice options via telephone or internet networks. Ensure families are regularly updated about the condition and location of their child in care. And provide updated information about the child's health status, possibility of reinfection, appropriate aftercare measures, and accompany family reinsertion with caseworkers, with caseworker follow-up to combat social stigma and other potential issues upon discharge. To provide child-friendly and family-centered care, it's also necessary to appoint at least 2 child protection focal points or social workers, 1 male and 1 female per center. Ideally, this is personnel with specialized skills in child protection case management, social work, mental health, and psychosocial support. Although in a pinch, it can also be health workers who have been trained on this role. These focal points provide an important resource for children and families, as well as health practitioners. They can monitor and follow up, advocate for appropriate and timely referrals and counter referrals, and they can ensure the overall well-being of children and their caregivers throughout their care process. Remember that centers operate day and night, so personnel need to be able to cater to child protection needs 24/7. Finally, but importantly, all facility staff, so that means everyone from doctors and nurses to cleaners and drivers who have access to children in isolation or care, should be fully vetted. They should be trained in safeguarding measures, and they should have understood and signed the code of conduct. This step should not be missed, even if rapid recruitment is ongoing during an acute outbreak response. We know that outbreaks create the conditions in which the risks of children's exploitation and abuse are heightened. In the same vein, children and their caregivers should also be made aware of an accessible reporting mechanism and encouraged to use it if concerns arise. Just before we pass over to case studies, I'll just remind attendees that they're welcome to use the Q&A function at the bottom of their screens to pose any questions to us panelists that we'll try to answer throughout this presentation. So without further ado, let me pass over to Dr. Charles to give us some concrete examples from the field. Thank you.
Thanks, Nidhi. So we are going to share some experiences from Cox's Bazar, where there were some outbreaks of diphtheria, COVID-19, as well as upsurges of dengue. And there were some isolation and treatment center and infectious disease treatment centers. So how we integrated child protection in the isolation and treatment centers and the infectious disease treatment centers. Let's see, like the child protection mainstreaming, it was within the strategy of the overall outbreak response. And we had focal persons trained on the child carer, and especially on the child protection and child-friendly communication. And these focal persons, they rolled out the same trainings for the healthcare workers and the other staff within the isolation and treatment centers. We had dedicated wards for the children with child-friendly equipments and design with appropriate safety measures, and also the measures for the amusement of the children. And we had the provisions of different arts, games, also some snacks and the music for the children, so that they can have some kind of some kind of a playful environment within the isolation and treatment center. There was a provision of psychosocial support from our MHPSS team, that is the mental health and psychosocial team, and they had that provision of support for the children, and they had different sessions, different events, and also arrangement of different sessions with them. We had the good linkage with the child protection actors. I mean the linkage between the child protection actors and the health actors, so that the support can be given to the children in case they need caregiver, especially if their mother or their parents are diagnosed with the COVID-19 or other infectious diseases. And also it was a good exercise to have the linkage with the child protection actors for supporting to the separate and unaccompanied children. There was a provision of space to meet the family members and friends during the period of isolation and quarantine for the children. And in the clinical care, we integrated the pediatric services, the medical equipments. These were also specified for the children, so we can especially address the special needs of the children. And we had risk communication and community engagement events, especially designed for the children and adolescent groups. In the photo here, you can see like we had artisans from the local community with costumes of mosquito and other dengue-related events, so that the child could be attracted with the event and having a proper idea on the dengue outbreak. And we had the provision of maternal and neonatal care service within the isolation and treatment center. So the neonatal care was integrated within the isolation and treatment center. Next, please. So there were some challenges as well, there was fear of the personal protective equipment because of, during the COVID-19, there were some special personal protective equipment, so the children might have fear, and there were some certain procedures like sample collection, intravenous catheterization, and oxygenation with masks. So it created fear to the children, but we tried to have some measures on that to so that the child can be engaged with that, and they are like oriented on the different personal protective equipment. So with that, we could reduce some of the fear of them. And another challenge was if a mother has multiple children, then sometimes all of the children needed isolation. So that's one of the challenges for the isolation and treatment centers. So the lesson learned, we need to integrate child protection from the very beginning of the outbreak response, and we need to allocate the budget and resources for that, not at the agency level, but also at the sector level. We need to consider the children during the health facility design, procurement of medical equipment and commodities, and treatment and care. So in every pillars of the outbreak response, we need to consider the needs and the concerns of the children. We should have the strong coordination between the health and child protection actors to strengthen the child participation and the protection, family unity, and case management. And finally, a special attention should be given to design and adaptation of the medical procedures and equipment friendly to the children, especially the personal protective equipments and the injecting procedures or the sample collection procedures that needs to be adapted in a way that is friendly to the children. That's all. I will pass to my colleague, Dr. Hans. Thank you.
Yeah, so thank you very much. So I will give a few ideas and reflections on experience from different Ebola outbreaks and experience showing that integration of pediatric care and child protection and needs of children in the care in Ebola treatment centers is possible. So since the 70s, several Ebola outbreaks have been reported. The largest happened in 2014 and 16 in West Africa. Another large outbreak in the eastern part of Congo, 2018 to 20. And just recently, there was a Sudan Ebola virus outbreak in the southwestern part of Uganda. Around 25% of patients treated in these treatment units were under the age of 18, and a considerable number of patients were under the age of 5 years. So it's very clear that we need to be prepared from the start of care of newborns, of young infants, children, and adolescents. Importantly, it's not only the patients with Ebola, with confirmed Ebola, we also need to consider the care of a large number of patients with suspected Ebola viral disease, which later subsequently may not be confirmed. Importantly, all of these Ebola outbreaks happened in countries which still face considerable challenges of regular health services. So an important element of a comprehensive approach to an outbreak response is also the support of regular health services. And here particularly maternal health and child health services are important. Next, please. So Ebola treatment centers should be built around the needs of patients, and here also children and pregnant mothers, their families, the communities, and the health workers. We don't want isolation. We actually want to have treatment in a safe environment. And this should, and the adequate setup of an Ebola treatment center then also facilitates the delivery of good quality of care. And there are WHO standards defined. And this includes adequate care for children and newborns. So needs of newborns, children, and adolescents need to be integrated and considered in the design of treatment centers. The treatment unit should be accessible and transparent for the community while ensuring privacy of patients and families. Ideally, treatment centers should be as close as possible to affected populations. There shouldn't be these large, massive treatment centers anymore. Therefore, preparation is needed, and we also need rapidly deployable treatment units, which can be moved rapidly to places where chains of transmission are ongoing. It is also helpful if treatment units are actually linked to regular health services. Next slide, please. So patient-centered care is as important as management of airway, breathing, circulation. And actually, clinical management should always be linked with patient-centered and child-friendly care. We need to communicate well with the child, with the parents, and that's possible. We need to assure comfort, pain treatment, positioning, mobilization. The environment need to be adequate, as outlined by the previous speakers. And once the child gets better, we need to stimulate, we need to play. Friends and family can visit because the treatment unit should allow visibility of patients at all time from the low-risk zone. That facilitates better surveillance, but at the same time also psychological support. Next slide, please. So Ebola treatment centers should be linked to family or rehabilitation units. We need to consider that there are children who are stable, tested Ebola virus negative, but possibly their parents or their families are admitted. We also need to consider needs of pregnant women recovering from Ebola, but mothers who may not have yet delivered in a treatment center. So they should be cared for while waiting for delivery in a safe environment, as they then need to deliver in an ETC setting. We also, after treatment of patients, need time for rehabilitation in a safe environment. We need time to prepare resettlement and reintegration in the community. We may have to discuss with the communities. We need to ensure the housing is all right and that socioeconomic needs are met. And this may need time. So rehabilitation units, an important part of a treatment unit. Next slide, please. So once patients are discharged from a treatment center, our work is not over. So we need to look after survivors, their medical needs. There may be medical sequelae like visual problems, neurological problems. And these patients and families need psychological support. They may have nutritional needs and they may be vulnerable for a considerable period of time. But we should actually have a wider perspective at the care of survivors. We need to look at vulnerable families of survivors and non-survivors. We need to look at communities who have been affected by the outbreak. And in this context, community-based survivor support groups can be extremely helpful. And that was, for example, an example in the Uganda outbreak just recently. Part of community support is strengthening and support of regular health services. And I think this is an important part we need to advocate for, that in an outbreak response, the support of regular health services needs equal attention as actually the care of patients with the index disease. And then in the long run, we need to develop community and health facility-based surveillance systems to detect outbreaks as quickly as possible, to actually prevent spread and uncontrolled outbreaks. And that then in the longer run also needs the link to rapid outbreak response teams. So thank you very much, and I hand over to the next colleague.
Brilliant. Thank you, Dr. Hans. That's great. We're going to come back to some questions for all the panelists now, and I can see that everyone's putting them in the Q&A, so thank you very much for that. We're going to revisit the poll and give you a chance to answer this again. Okay, no, we have the results. Okay, so we asked a question, what do you think are the biggest challenges to integrating child protection into the design and operation of isolation and treatment centres? So I can see that there's a lot of challenges. So we have budget constraints and lack of staff training coming out on top, followed by limited time in the emergency phase of outbreaks, and health actors not seeing integration as their responsibility, and also strict infection prevention control procedures. Okay. So we're going to try and incorporate these into some of our question and answers. So if I just welcome back all of the presenters and panelists, if we could all put our cameras on. Thank you. So I think the first question that I saw come up in the chat a couple of times, and I think is reflected in the poll, is around budget. I think a couple of people had mentioned, we don't even have budget for very simple measures outside of outbreaks. So I think I'm going to ask this one to Nurian. So Nurian, I was wondering if you can elaborate a little bit on how humanitarian health actors can ensure child protection interventions are budgeted for an isolation and treatment centre. Nurian, to you.
Thanks. Thanks for the question. I know budget is always comes up as a main topic when it comes to integrating different services together. In this case, I think we need to remember 2 points. One is the children's needs to protection, learning, and the play will not disappear because they are either isolated or admitted in the treatment center. So they will have their needs. And the second thing we need to remember is that if we look at all the humanitarian donors, all donors, they want to fund or they want to prioritize programs which integrating many different sectors. So we need to, like the health people who needs to design the program interventions, need to understand why do we need to integrate child protection into health service delivery and what kind of activities we can do, what kind of resources needed. And a couple of examples of budgeting. One important thing is we need to include budget for human resources. For example, child protection focal point, or a mental health psychosocial support specialist, or education specialist, depending on how long the child is going to stay in the isolation center. The other important key role we need to include in the budget is the community liaison person. The person who liaises with the isolation center and the community where the isolation center is based. So that person can act as a bridge between the children who are admitted in the facility and their caregivers or family members. The other things we need to budget is the supplies and other equipment we need to make the isolation treatment center child friendly. I will stop here. Thanks.
Thanks, Nurian. That was very comprehensive. Thanks for that. I think as well, linking on from funding and budget, there's a question here directly to Dr. Hans about to what extent is critical care feasible in these outbreaks in what usually happen within resource limited areas, and how do we save a child who needs these and the next available centre is miles away? So I think this kind of links to where we put isolation and treatment centres amongst other things. And then I'd just like to add on to that, Dr. Hans, your experience of health actors and their engagement with these types of issues that we have around child protection. I think in the poll it said very strongly that people, that health actors especially, are not seeing this as their responsibility. So yeah, it would be interesting to hear from you on these 2 points.
Yeah, so thank you very much for this question. Yeah, I think we can deliver essential critical care. And what do we mean with this? This means that we have oxygen available, that we can manage shock, that in a district regional hospital level, we have access to safe blood transfusions. We can manage neurological emergencies and co-infections. So I think this is quite clearly outlined also in WHO guidelines. And I think our ambition should be that we can deliver this level of care also during an outbreak. But right, so we need to be prepared. So ideally, countries have treatment units linked to emergency departments who can see patients with suspected highly infectious diseases. And that's also including measles and diphtheria, but also Ebola or Lassa. And then these units should have surge capacity. So if we really detect a patient with a highly infectious disease, then a district or regional task force can ask for support from outbreak response team. This level of care can only be provided if the ETC is set up properly. And I think these key design principles, decentralized and visibility of patients is crucial. And today, I think all health actors who build treatment centers for Ebola or other highly infectious diseases should ask for review and support of WHO and associated experts. I think it's not justifiable anymore during a next outbreak that we have treatment centers who do not respond to these standards. Yes, I think providers or actors in outbreak responses, we need to advocate that they consider child-friendly and mother-friendly care as one of their responsibilities. I think there can't be an excuse of funding. In this we have enough funding. We need to plan and we need to consider it. So I think this is feasible, and I think we need to advocate that all actors consider this as one of their key responsibilities. Thank you.
Thanks, Dr. Hans. I appreciate that. Can see, I think sometimes when we talk about children, there is often sometimes a tendency to think of them as a homogeneous group, but we know that children have different needs and different influences in their life. And I think there was one comment around what to do if the child is actually a mother herself. So I think I'm going to ask this one to Nidhi. So how can isolation treatment centres accommodate for the needs of children that have not only a diverse and differing needs, but also things like disability or even their caregivers having special needs? Over to you.
Thank you, Sarah. Of course, there's many different factors to think about that will be difficult for me to cover just in 1 or 2 minutes, but I think the key takeaway is to really focus on the holistic needs of that child or that family. And so to really understand, how can we make the accommodations necessary in order for them to receive the best care possible in the safest way possible. So think about things like dedicated family wards, keeping mother and baby together. I see there's other questions coming up in the chat about what happens when we have to separate. I think as Aisha mentioned, separation is the last possible resort. Yes, it may be necessary with certain infectious diseases. However, in most cases, work can be done actually to ensure strict adherence to infection prevention control measures to allow the family to stay together. And so hopefully Aisha can step in also to provide further details on that. But I think there's a whole area of work that can be done to ensure adherence to those kinds of measures and keep the family together. In cases where separation is necessary, then of course we need to think about the introduction of some type of caseworker. So there has to be a child protection focal point or a social worker or psychosocial specialist who is on hand to assist health workers with the other needs that child or family will present. In terms of children with disabilities, yes, we often think about things like ramps to the center, maybe physical accessibility, but remember that disability comes in all different forms. And it could be that we might have children with visual impairments, hearing impairments, sensorial impairments. So think about that full spectrum of what disability entails. And that might be encouraging when we do procurement of child-friendly materials. Can we have some Braille in materials? Can we have some large font materials? Can we have sensitization or training of our health worker or any center staff who will have access to children? Can we make sure they have disability sensitivity training? Can we make sure that they have been trained on some basic communication and disability sensitive kind of methods? So I'll leave it there just because of time. I don't know if Aisha, you want to step in to complete anything I've said in terms of keeping families together. Thank you.
Yeah, no, thank you. And thank you also for those questions, because I think they're really, it's tough, especially when you have like what we saw with COVID, when we didn't know, what the risks were and where the transmission, sort of how it was occurring, who was highest risk. And so what happened was basically there was a lot of separation going on, also mothers and newborns, children from their families. This was done until we sort of had an understanding of, oh, okay, maybe that's not necessary. There was sort of a reflex response, which was actually very harmful, and in the end turned out to not be necessary and not appropriate. Again, there are times when it is appropriate or it's the only thing you can do, and when that's the case, then the key is to find a solution to make sure the child has adequate care. So it's staffing to be able to provide care, which will be much more intensive for younger children, babies and younger children, than it will be for example, a 14-year-old. But that also then making sure that that we're aware of if the child is distressed or when they're distressed, to respond to that, and to do all the things we can do, as Dr. Hans mentioned, to make sure that we can minimize that. So part of it is also around part of the care for children is once they start to improve, to make sure we stimulate them. We do this with malnutrition as well. This is really critical for really all child illness, but once they're starting to get better, we need to kind of help them to start moving around and to be kids again. It's very difficult in an isolation and treatment center, but there are things we can do to help them to play, and we can provide spaces for them to do that. And we can also safely have spaces where in a low transmission or low risk zone, where they can see their family and their caregivers. So that's very helpful for them. That's for everyone. So there are ways to try and minimize the harm when separation is needed, but when it isn't necessary, it really shouldn't be done. And I think there are a couple of questions in the chat also around the Q&A around supporting young children who are temporarily separated from their caregivers and how to help them to understand. And so they're, using child-specific language. And I think there's maybe a need to develop. There's a really actually big need to help caregivers, sort of health workers, to have protocols and training on how to speak to children. I appreciate that not everybody who's working in an infectious disease outbreak in an isolation and treatment center is a child health specialist. So, but to learn, to make sure that staff have some protocols available so they can understand, some training in how to speak to children, because you don't use, in the same way we don't use very technical language to speak to patients, physicians shouldn't be using that. We should be using language that an adult can understand. Same as for children. We just adapt our language to help them. Okay, the child, your mother's very sick. She's getting care in this place. You know, you can show them where it is. They can understand that they're there. Help them to also anticipate what you know might happen. Never promise that it's all going to be okay, because we don't know that. Don't make promises you can't keep. That's very, very important. And but to just answer their questions and allow them to ask. This is also very important, because not talking about it, the silence, is what also perpetuates the stigma. And it also makes children worry that they are the problem, that they've caused this. And so it's really important to hear the children, to give them a space to talk and to respond to what their questions are, what their thoughts are, to acknowledge their thoughts when they share them, and to respond. I don't know if this helps. And also, I don't know if I can pass on to Hans to talk a bit further.
I just want to, sorry, we've only got 2 minutes left, but thanks, Aisha. I just want to answer one last question. I know we've got lots of questions. I don't think we're going to have time to answer them all. But there was several things that came up. I was struck by one comment that said that it seems like it's a big effort to integrate child protection into outbreak response. And also one question around the practicalities of doing it when you're dealing with a highly infectious disease and there's infection prevention control measures that need to be brought in and abided by. So I'm just going to give this last answer to Dr. Charles, because I know he's done a lot of this practical implication interventions. So Dr. Charles, can I ask you, is it a big effort to integrate child protection into outbreak response? And what are some simple practical examples of adhering to infection prevention control procedures, but allowing children to do things like play and see family? Over to you for the last minute.
Thanks, Sarah. I think we have to integrate the child protection, this concept from the beginning of the outbreak response strategy. And by having this, there should be a culture within the healthcare workers and healthcare setting to have the child protection in the system. It's not about sometimes budget, but also within our behavior and our skills. So with some simple strategies, like having some of the standard operating procedures within the isolation and treatment centers, having some trainings. It not to be a in-house training, but it could be like CMEs for the healthcare workers, so that they have some skills and behaviors and some attitudes toward the children and the caregivers. So with that, like some examples can be some toys, snacks for the children, so that can be disinfected. And there could be during when you have the child protection concerned in the design phase of the isolation and treatment centers, you can have some spaces, maybe with some distancing, so that the children can see their neighbors, their families, their friends. And like there could be arrangement of some music, some songs for the children. Even there could be celebration of some parties, like birthday party for the children within the ward. So like some events, they can be we can create an environment where the children feels they are not quarantined, they are not in a jail, but they are within their community. And like as I said, for the infection prevention and control, if you want to balance that, actually sometimes most often, like it's not about to as our other colleagues said, it's not about to separate the children from the mothers. In many cases, mostly the children can be with their parents. So that things we need to consider, and we also have to, like as I said, like we have to create a culture within the healthcare setting to have the child protection concern mainstreamed. Thank you.
Thanks, Dr. Charles. And I'm afraid that's all we've got time for now. So just to close, I hope you found today interesting, insightful, meaningful, and that you walk away with some ideas on child protection integration and why it's so important for isolation treatment centres. Recommended further reading will be sent out to you, but please visit READY's resource library, which you can see now, and the link should be in the chat soon. Lots of multi-sectoral tools and guidance for outbreak readiness and response. Also the Ready Learning Hub, over 60 courses on there, all accessible for free, and lots on child protection too. So please also provide us feedback with for the webinar, and there will be a link to the survey in the chat also. So thanks again to all the panelists and presenters. We had a lot to get through, and I think we've managed to do some questions. Thanks to the interpreters, special thanks to BHA and our regional colleagues in Eastern South Africa and Cox's Bazar, of course. And thanks very much to the audience for all your insightful questions and comments. Please join us for the last webinar in the series, which will be February 15th. At 12:30 GMT, 15:30 East Africa time, which will be communicating with children in infectious disease outbreaks. Look forward to seeing you then, and thanks very much for joining. Good morning, good afternoon, good evening. Thanks, everyone.
Bye to everybody.